All right, so you made it. We are at the last section of this lecture. In this section, we will talk about the use of antiretroviral therapy to prevent HIV, both in pre-exposure and in post-exposure prophylaxis. So what's the difference between the two? Post-exposure prophylaxis is when a person has an exposure and they weren't expecting that that exposure would happen, and we now are trying to catch up and prevent any transmission. Whereas pre-exposure is a person is defined at high risk or kind of knows that there might be the chance of an exposure and is trying to prevent it before it happens. So in a very poor simile, you might kind of consider these as the way we use contraception, in that combination oral contraceptives are used before an exposure for women who don't want a pregnancy, but who are having sexual intercourse. They know that there's the chance that they might become pregnant, so they're doing something to prevent the pregnancy from happening beforehand. We would then need to consider that for women who either were not taking or had missed doses of their oral contraceptive, or who had had an exposure, the condom slipped, or they were assaulted, there is the option of Plan B, or medications that you can take after the exposure to prevent pregnancy. And we can consider these as examples of how pre and post exposure prophylaxis work. I will say that it is not a clean simile, and I almost feel bad making it because antiretrovirals are only used for HIV or hepatitis B, but combination oral contraceptives can be used for a lot of different indications, and many of them are not related to contraception. So do recognize that even though I know it's a poor analogy, it does kind of serve the purpose. So what is post-exposure prophylaxis? Post-exposure prophylaxis, like I said, is when you are giving medications after an exposure to prevent the transmission. Two types are available, but the guidelines tend to be the same for both. One is non-occupational, which is when it doesn't happen on the job, and one is occupational. The difference between the two is only that non-occupational is more than just antiretrovirals. We have to consider antibiotics, we have to consider contraception, we need to consider viral hepatitis. All of those will play a role in non-occupational post-exposure prophylaxis. In regards to their HIV medications, regardless of whether it's occupational or non-occupational, all people are getting 28 days worth of their regimen, which is usually initiated in the ER. We will talk a little bit about the use of pharmacies in post-exposure prophylaxis in a little bit. To work effectively, we have to start within 36 hours, according to the New York State guidelines, or 72 hours according to the CDC guidelines. The sooner you start these medications, the more likely they are to work. And the question always comes up, well, what happens if you've got somebody who within 48 hours came in and said that she had been sexually assaulted, and it took her the 2 days to kind of get used to the idea and deal with the stigma of potentially coming forward. So she's at 48 hours, and that's more than 36. Do we still give her the medications? Yes, we do. We do recommend that the person is counseled that the sooner they started, the better, but we are still going to give this medication. The last thing you want to do is add further concern or further anxiety to somebody who's already been through the ringer. So one thing I would suggest is that in cases where you are in an occupational setting, or where you know the source, we do recommend that you ask the person. So if you were doing, you were teaching somebody how to use their glucometer, and you had pulled the lancet out, they had poked themselves, and as you were getting ready to throw it into the biohazard bag, you stuck yourself. Generally speaking, that's not enough of a, it doesn't go deep enough that you need to worry too much about actual transmission. But if you are concerned, ask the source, ask the person that you were working with, hey, have you ever had an HIV test? If you have, what are the results? Most people are very open about being honest that they have had one, that they haven't had one. Some people will tell you that they have and that they're undetectable. In those cases where you have asked the person and they tell you they're not, then you really don't need to worry too much about going through the 28 days of the medication. That's often a very uncomfortable set of questions to be asking somebody, but they understand that you're concerned about your own risk, and they're not going to take it personally or think that you're thinking less of them. It's always a good idea to ask the questions. Kind of in a different lane, regardless of whether the person knows who their assailant is in a sexual assault or not. They are all considered at high risk. So those people, we're going to be doing post-exposure prophylaxis regardless. And when it comes to post-exposure prophylaxis, we do HIV testing at baseline to make sure that the person who was exposed was not HIV positive to begin with. We'll do it again at week 4, which is after they've completed their 28-day regimen, and then we'll do it again at week 12 just to be sure that the result was accurate. Couple of slides about sexual assault, because I would be remiss in not mentioning this. When it comes to sexual assault, the lifetime prevalence in the US is that upwards of 19% of women will have come forward with complaints of having been sexually assaulted. The lifetime prevalence in men is about 2 to 3%. But the thing to keep in mind about these is that these are only the people that have reported it. And there are so many reasons that a person does not report it. And I'm sure that, in the Me Too movement, all of you can kind of come up with your own ideas about why people do or don't. But the data suggests that only about 10 to 15% of assaults are ever reported to the police. So this data is grossly it's not accounting for all of the people who have actually been sexually assaulted in their lifetime. It's only the ones that are reporting it. One study suggested that in college-aged women, the cumulative rate over the 4 years that they're in college is that a quarter of them, 25%, had been sexually assaulted during their time on campus, and 30 to 80% of those did involve drugs or alcohol. One problem with this is that the majority of those have had some acquaintance with their attacker, so they know who the person that attacked them was, and this makes it much less likely that they're going to report the attack or the assault. In men, the people who are most likely to be sexually assaulted are gay and bisexual men, veterans, prison inmates, and those seeking mental health services. What's interesting about this is that it wasn't until 2013, 7 years ago, that the definition of rape actually was expanded to include men. So before 2013, while sexual assault did occur with men, they weren't actually counted in the numbers. So what do we do when we are evaluating a sexual assault survivor? Entire lectures could be given about the physical and psychological evaluation and the supportive care for these sexual assault survivors. But for right now, we'll talk about the medications. But we do need to consider that these sexual assault survivors will have an assessment. We'll be treating their physical injuries. We'll be focusing on their genitalia, their rectum, and potentially even their mouths. There is going to be a psychological assessment, and we're going to provide as much support as we can to those people. And for women, we will be assessing and preventing pregnancy, but in all members or all people who have been sexually assaulted, we're also going to be looking at the prevention of sexually transmitted infections. There will also be a forensic evaluation, which is when they take samples. Anybody who has watched primetime TV or has paid attention to the news know that one of the concerns that sexual assault survivors have with coming forward is that there's a backlog in actually evaluating the forensic data, which makes it very difficult to come up with an open and shut case. So people are very concerned that there may not be a reason to go through it if there's no chance that it's going to result in the conviction of the assailant. From the medication side, when it comes to post-exposure prophylaxis after a sexual assault, we are considering the sexually transmitted infections. I'm not sure if you've had that lecture yet or not, but if you have, you'll recognize ceftriaxone, azithromycin, and metronidazole. Do note that this regimen does take care of gonorrhea, chlamydia, and trichomoniasis, but it does not treat syphilis. There's also no prevention or way of preventing any sort of hepatitis C exposure. And when it comes to preventing pregnancy, the 3 options that are available are the ulipristal, the levonorgestrel, and the UTSB regimen. We tend to recommend the ulipristal as an option because it tends to be effective for up to 120 hours post-assault, and that's just a 30 milligram dose. Levonorgestrel or Plan B could potentially be an option, usually most effective within 72 hours, but it may be considered still efficacious for up to 120, and there is some concern that it might not be as effective in overweight women. And the last method is the use of your combination oral contraceptive at a regular scheduled time. So the question that comes up all the time is, how are these drugs paid for? Some people will have insurance that will pay for it, but in a vast majority of sexual assault cases, the Crime Victims Board will actually pay for it, and the state is in charge of the Crime Victims Board. So these medications are paid for. For post-exposure prophylaxis, while we can't do anything about hepatitis C, we can do some work with hepatitis B. Most people born in the last several decades are vaccinated at birth. So we do know that most everybody is vaccinated, but if somebody has not been vaccinated or they're not sure of their status, this is how you would deal with this. I will say that hepatitis B is a very complicated disease to treat and to work with, and I know you haven't had a lecture about hepatitis B, so I'm not going to ask you to memorize any of this, but do know when you're thinking about the full picture of somebody who's been sexually assaulted, you should be asking about their hepatitis B status. And since we've talked about sexual exposure, we should talk a little bit about the occupational exposures as well. There is a lot of concern from people who work in healthcare that they might have an exposure. There's only been one confirmed case of an occupational transmission after 1999, and that was a lab worker who was working directly with HIV. Some statistics, just so that you're kind of more comfortable with the likelihood of being infected, the incidence after a percutaneous exposure is less than 0.33%. Following a needle stick, it's less than 0.36%, and following a mucosal exposure, something like the mouth or somehow, some fluid got in your eye, the likelihood is less than 0.03%. These risks are increased if there was a deep exposure, if the device that you got stuck with had the source person's blood on it, or if the patient had a high viral load. Remember that a lot of fluids are not considered infectious. So if a patient spits on you, I've had instances where we've had members who were working with psychiatric patients, and somehow the member wound up throwing their urine at them. These things do not have HIV in them, so there's no need to do post-exposure prophylaxis as a result. And the other question is, how are these drugs paid for? Obviously, they're not dealing with the Crime Victims Board. They're dealing with workman's comp. So these medications, regardless of the situation, are paid for. And I think sometimes when we're working with pharmacists in the community, there's a real concern about, well, you can't get this until you pay for it. Holding up the use of these medications until they're paid for oftentimes is the difference between getting them on the medication and not, and then expecting and seeing whether or not they're going to be HIV infected. So start them for ethical reasons, but you will get paid for these medications. It just might not be the day that they're asked for. And like I said, there is currently in New York an initiative to start providing post-exposure prophylaxis in pharmacies. And how this would work is that the pharmacist has to be under a non-patient specific standing order in relation with a licensed physician or nurse practitioner. Pharmacists can dispense a 7-day supply, and in that time, they are linked with a prescriber. The prescriber evaluates the patient and then will give the rest of the prescription. In most cases, follow-up is going to happen within 1 to 3 days. And the reason it happens 3 days or more later is that you've got somebody who has an incident on a Friday, their doctors are closed on Saturday and Sunday, and then they have to come in on Monday. So it's not like people are waiting 3 days in most cases, but just know that they are given 7 days just to be safe. Some problems with how this is working in New York: pharmacists can't provide any sort of point of care testing, so we can't do HIV testing in our own areas. I will blame the very conservative New York State for that one, and leave it at that. There's also some concern about finding providers who are interested in working with the pharmacist, and that is a result of either a lack of education about this whole situation, or there's honestly a very real fear that some healthcare providers think that the pharmacists that are doing this are stepping on their toes or are somehow going to steal their professional role. Obviously, neither one of these is the case, but it is sometimes very difficult with organizations that are working in silos to find providers that are interested in partnering with community pharmacists. Another issue from the community pharmacy side is that they are concerned about breaking open Truvada bottles and only giving 7 of them and then having to waste the rest. These medications are stable at room temperature for upwards of 6 weeks, so there is no concern that you have to throw the rest away immediately. And the other thing that has been kind of helpful is that a lot of providers that are doing post-exposure prophylaxis have gotten so kind of fed up with the idea that they can't get 28 days worth of their Truvada that they've actually started ordering 30 days just to get the medication without complaints on the pharmacy side. Again, payment is always an issue, but for people who are working in community pharmacies, do know that Workmen's Comp or the Crime Victims Board will pay for most of these if it's an assault or an occupational exposure. And most private insurers and Medicaid and Medicare will also cover for these medications. Also, we're going to talk about pre-exposure prophylaxis. So how effective is pre-exposure prophylaxis? When it's used every day, which is the only way it's FDA approved right now, it's 99% effective at preventing HIV. There is a role for on-demand PrEP, and when they do the studies in on-demand PrEP, it's 90% efficacious. Most of the reasons that it's not efficacious in those on-demand PrEP is that they're not using it the way that it should be following the dosing routine. What is on-demand sex? On-demand sex is when you don't usually have random sex and you kind of know when you're going to be having sex. Say you have a husband who's in jail and you only see him on certain days, or your boyfriend or girlfriend is living out of town and they're coming in for the weekend. Those would be reasons that you might have on-demand PrEP. And the way that that's used in all the studies is that within 2 to 24 hours before the actual sex act, you take 2 tablets, then you take 1 tablet 24 hours later, and then you take another one 24 hours after that. So it's 4 pills per sex act. And one of the concerns is that even if you have sex twice a week, that's 8 pills, and that's already more than taking it once a day. So you may as well just be taking it once a day. Data suggests that in 2018, there were 132,000 people using this medication, which would be nice, except that more than 1.1 million of them have indications for it and might find it beneficial. There is a number of reasons why this is the case, and we'll talk a little bit about some of them, but there's also concern about the fact that uptake is limited in underrepresented populations. Some reasons for this are that when it was first kind of announced as an option, many people thought it was only for gay men, and one of the concerns was that even amongst gay men, it was only for white gay men, or it was never advertised as being an option for men who have sex with men from underrepresented populations. There is still a very real kind of distrust of the healthcare system among marginalized or underrepresented patient populations. And another big reason is cost, and we'll talk a little bit about that a little bit later. So who should be counseled about the option to use pre-exposure prophylaxis? We should be considering this in men who have sex with men, any adult who has sex with an HIV-positive partner that has a detectable viral load. We have to consider using this in sex workers, male or female. We're going to consider this in trans females, as they are one of the risks, one of the groups that are at the highest risk of HIV transmission. But again, it's because of their marginalized status. Injection drug users may potentially find benefit, and heterosexual men or women who have had a recent bacterial STI might find benefit because it's proof that they are having unprotected sexual encounters. Anyone who has sex without knowing their partner's serostatus, which is very likely in the age of online hookups. Anybody who has used the apps or has seen the apps knows what I'm talking about there. And really anybody who asks about it. So one of the things that comes into play is that sometimes people will ask about it and you won't think that they have any sort of risk that puts them at risk. They have heard about this medication and they will always know more about their risks than they're willing to disclose to you. So if somebody is asking you about pre-exposure prophylaxis, it's worth having that conversation, because even if they don't disclose their actual risk factor, they themselves think they've got one, and that is often enough. So what are the 2 drugs that we use? One of them is tenofovir disoproxil fumarate with emtricitabine, and the other is tenofovir elafenamide with emtricitabine. The differences between the 2 are obviously the concern about the creatinine clearance, but interestingly enough, the Truvada is approved for all patients regardless of their gender or sexual orientation, and currently Descovy is only available for cis men and for trans females. So especially concerning is for those females who are concerned about the levels in their cervical cells. We don't have enough good data to suggest that Descovy could be used, and those studies are ongoing, but at least currently, you can't use Descovy in a cis female. You can only get a 3-month supply at maximum before you have to get an HIV test to confirm your negative status, and then you get the next 3 months. You can be on this as long as you want to, or as long as you think you need to, and we'll talk a little bit about that on this slide in just a bit. I do want you to remember that STIs do increase the risk of HIV infections, so pre-exposure prophylaxis may not be as effective if a person does have an untreated bacterial STI. Again, when you're talking about duration, if you are somebody who is newly with an HIV positive person and they are just starting medications, you're going to want to wait for those medications to work and for your partner to be undetectable for at least 6 months before you stop using pre-exposure prophylaxis. But people can be on this medication for as long as they think themselves at risk. And one of the other concerns is that, say somebody's lifestyle factors have changed, they are a gay man who has been playing the field for a while and then falls for one of their partners and they stay together for a couple of years. If they decide to make it a monogamous relationship, that person might decide to stop taking pre-exposure prophylaxis. And then if, worst case scenario, they wind up breaking up and he gets back out in the field, he can absolutely go on the medication again. So it's not one of those that you start and then stop and then can never use again. If your lifestyle circumstances change, you have the ability to use it as many times as you need. What sort of baseline tests do? We do HIV testing, pregnancy testing, viral hepatitis, STIs, and then renal function. And we are going to be asking about risk factors for osteopenia. At every visit, which happens every 3 months, we're going to also be checking for signs or symptoms of acute HIV infection, continued medication adherence, and any sort of risk reduction counseling. We talked a little bit about the cost, so I do want to at least touch on that. The costs for this medication are exorbitant. Both drugs are made by the same company, and at least currently, neither one of them has the ability to make generics. The Truvada generic is supposed to come out in September of this year. There are patient assistance programs which will work for some people, but if you don't have a good insurance or you're not qualified for the patient assistance programs, the cost for either one of these medications could be upwards of $2,000 a month, and obviously that's going to be a huge adherence barrier. The other question that comes up is, well, should primary care providers be doing this, or should specialty care providers be doing this? People who work in HIV or infectious diseases on a regular basis. My soapbox would be that this should be treated like all issues pertaining to any USPSTF recommendation. They do recommendations about colonoscopies and mammograms. They do recommendations about how often you get your blood pressure or cholesterol checked. They do recommendations about vaccines. They also do a recommendation about HIV testing and about pre-exposure prophylaxis. And the grade for pre-exposure prophylaxis is an A. And if primary care doctors can do all the other things, they should be able to do this pre-exposure prophylaxis as well. And the reason that they don't is that stigma is preventing that from happening. Some questions or concerns that have come up on the provider side in terms of why they don't want to do it is this idea that to start doing it well, you have to ask the right sexual history questions, and that's going to take too long. And what happens if they start telling a story that you don't want to hear? A good sexual history takes less than 5 minutes to complete. And it doesn't have to add time to the primary care visit if the nurses that are doing the intake are the ones that ask the questions and the provider is the one that kind of deals with the results. So just a soapbox, a lot of people are trying to figure out where and when this is going to fit in and who should be doing it. My suggestion is that this should be at all primary care offices, but this is taking a little bit longer than it should. All right, so you've made it through my lecture. Like I said, there's a lot of information in here. I apologize. I could definitely talk for hours and more hours about this, and I won't. If there are questions, let me know. If there are concerns, let me know. And I will put together a couple of fact sheets regarding this over the next couple of days so I can post it for you as well. Thank you. Hope all's well. Hope you're staying well. Bye-bye.